It's a great pleasure to have him here today. Dr. Pandey is an associate professor of internal medicine at the UT Southwestern Medical Center in Dallas, Texas. He did all his training in internal medicine and cardiology fellowship there. He is a very successful physician investigator with an extensive experience with prospective observational studies, cardiovascular registries, and randomized clinical trials with advanced training in research methodology. His research has focused on understanding the heterogeneity in the risk of cardiovascular disease among at-risk individuals, using pooled data from multiple cohorts and leveraging machine learning-based analytic approaches. He has developed a novel heart failure risk prediction tool for community-dwelling individuals. And he has also created machine learning-based clustering approaches to identify the pathophysiologic basis of heterogeneity in cardiometabolic diseases such as diabetes and heart failure. He works also with phenotyping data, including data on cardiac imaging with echocardiography and cardiac biomarkers to stratify risk for incident cardiovascular disease. So congratulations again. We were chatting a little bit before. He has multiple papers in circulation, JACC heart failure. So a real rising star in research in prevention. Thank you for joining us.
Thanks, Leandro, and hello, everyone. I'm excited and delighted to be here to give this talk on leveraging big data, machine learning approaches, and health technology to improve cardiovascular health for all. Here are my disclosures. So the burden of cardiovascular disease is already pretty high, and it is expected to increase even further by 30% in the next 10 years. And concurrent with the rising burden of cardiovascular disease, the cost of healthcare is also expected to increase by almost 200%, highlighting the growing epidemic of cardiovascular disease in our community. Some of this rising burden of cardiovascular disease is related to the aging population and the high lifetime risk of heart failure and coronary artery disease in our population. And another key factor that is contributing to the increasing burden of cardiovascular disease is the worsening trajectory of cardiometabolic health in our population. And we can take a glance at that in the figure shown here from the recent work from NHANES that has demonstrated an increase in the proportion of individuals with type 2 diabetes without optimal control of glycemic status over the recent time period. Similarly, the optimal control of blood pressure has also been not at the desired rate, as shown in the figure on your right, where we can see that over the last 3 decades, the proportion of participants with optimal control of blood pressure has been lower. And I think in the recent last 10 years, the proportion has been even going down, highlighting the need for better approaches to risk factor control. And the worsening cardiometabolic health trajectory is particularly important for heart failure burden, as recent data from our group have shown that over the past 6 years, there has been a plateau in heart failure incidence decline, and individuals with prevalent cardiometabolic risk factors have had up to 2 to 7-fold higher risk of heart failure. These data come from some of the work that was led by Dr. Rohan Khera, who was a fellow at the time in our institution, and he did some of the leading work related to understanding the epidemiology of heart failure and the correlation with the rising burden of cardiometabolic risk factors in our community in the contemporary population. Furthermore, the worsening burden of cardiovascular disease has disproportionately affected individuals of self-reported Black race, with much higher incidence of premature cardiovascular disease among Black men and women than individuals of white race. And there are also variations noted not only by race, but by geographic location and by county level socioeconomic status in the longitudinal trajectory of cardiovascular mortality, as observed in a recent analysis from our group led by Dr. Shreya Rao, who was then a fellow with us and now leads the cardiovascular disparities program at UT San Antonio. And in this study, she demonstrated that there was a 2-fold variation in cardiovascular mortality rate across county clusters, and the decline in cardiovascular mortality has plateaued in the past 2 decades. Furthermore, the counties in the highest cardiovascular mortality cluster had the higher burden of socioeconomic distress, as shown in the Crowpath plot on your right. Racial disparities have also been reported in the cardiometabolic risk factor control and use of cardiometabolic therapies, with worse control of blood pressure among individuals of self-reported Black race and ethnicity, as shown in the plot on your left, and lower use of GLP-1 agonists among Black, Hispanic, and Asian race or ethnicity patients, as shown on the plot on your right. More recently, in a collaborative work between our group and Adam Bress's group at University of Utah, led by his fellow Dr. Josh Jacobs, we have demonstrated a substantial underutilization of statins for primary prevention among Black and Hispanic individuals across the strata of ASCVD risk. So only 1 in 4 Black and Hispanic individuals with ASCVD risk as high as 20% are on a prescription of a statin in this primary prevention population. So much work remains to be done to improve cardiometabolic health and cardiovascular outcomes in our population. And as we see it, there are 4 key challenges to optimal prevention. First, the risk of cardiovascular disease is heterogeneous, with wide variation in the risk of adverse events among individuals within a population. Effective therapies are often costly and limited in access because of both these reasons, and the one-size-fits-all approach to prevention has largely not worked. Third, the disparities in cardiovascular and cardiometabolic health has worsened over time. And finally, there is a substantial implementation gap in getting effective therapies to people who need the most. So our research group has tackled these challenges using some unique approaches. These include the identification of modifiable cardiovascular risk factors, the use of risk-based approach to prevention that targets individuals with elevated but modifiable risk. And we have also developed risk prediction strategies that lead to a more equitable risk prediction and allocation of therapies. And finally, we have developed and evaluated some novel implementation strategies to improve uptake of guideline-recommended therapies in this high-risk patient population. Our research group has specifically focused on developing these solutions in the context of preventing and predicting and managing heart failure, and which is what I will be focusing on over the next 30-35 minutes. So with regard to the solution of identifying modifiable risk factors, a common theme underlying the heterogeneity in development of heart failure, particularly heart failure with preserved ejection fraction, which has been recalcitrant to most therapies that are available, has been the role of physical inactivity and low exercise capacity or fitness early in life. And a series of work from our group using epidemiological data has demonstrated that physical inactivity and low fitness in midlife are key factors associated with development of heart failure. And when we have looked at this using objectively measured exercise capacity levels, we have observed significant patterns of a significant dose-dependent association between increasing cardiorespiratory fitness categories and risk of heart failure among patients with type 2 diabetes who were part of the Look Ahead trial in our work done in collaboration with investigators at Wake Forest. And as you can see in the graph on your left, increasing fitness levels among these individuals was associated with a greater decrease in the risk of heart failure as seen on, and over time, when these patients had a repeat assessment of fitness, a 10% increase in fitness was associated with up to 12% lower risk of heart failure on follow-up. In subsequent analysis from the Look Ahead trial, led by our then T32 fellow, Dr. Karsha Patel, who's now leading a cardiometabolic health program at Houston Methodist, we demonstrated that the kind of weight loss that happens in these patients with lifestyle intervention also matters when it comes to heart failure risk. And we observed that it was the decrease in estimated fat mass and central adiposity that was associated with a significantly lower risk of heart failure. In contrast, changes in lean mass were not associated with heart failure risk. And in more recent analysis from the Look Ahead trial, we demonstrated that clustering of optimal cardiometabolic health parameters among individuals with type 2 diabetes who were enrolled in the Look Ahead trial is associated with a graded reduction in heart failure risk. And here we looked at cardiometabolic health parameters such as optimal glucose control, blood pressure control, optimal kidney function, and optimal central adiposity parameters, and observed that compared with individuals that had none of these parameters optimally controlled, those with most optimal control of these cardiometabolic factors had 8-fold lower risk of heart failure, highlighting the need for aggressive risk modification to modify heart failure risk in this patient population. And thus, healthy lifestyle and optimal cardiometabolic health is key to heart failure prevention. While that works in theory, if you look at how the cardiometabolic interventions have performed when it comes to preventing heart failure in type 2 diabetes, as you can see from this table, among individuals with type 2 diabetes, intensive lifestyle intervention, which was evaluated in the look-ahead trial, intensive glycemic control, and lipid management and intensive blood pressure control, which were all evaluated in the ACCORD trial, had actually no effect on heart failure incidence in the trial setting. And there is more good news over the recent past years where we have had some positive developments for heart failure prevention strategies in diabetes with emergence of SGLT2 inhibitors as an effective pharmacotherapy for prevention of heart failure, and with a series of phase 3 cardiovascular outcome trials demonstrating up to 37% reduction in heart failure risk with these therapies. And while the emergence of SGLT2 inhibitors has been one of the most promising stories for management of patients with diabetes in the last decade, their utilization in the real world has not lived up to the expectations. And as you can see in the graph on your right, the data from these large analyses from a nationwide electronic health record-based registry shows that only 10% of patients with high-risk characteristics who have diabetes are indeed on SGLT2 inhibitors, highlighting the large implementation gap in uptake of these potentially life-saving therapies in this high-risk patient population. And thus, our lessons from the look-ahead ACCORD trial and the real-world utilization data from SGLT2 inhibitors suggest that there is a need for a more personalized approach to targeting cardiometabolic health interventions so that individuals who need it the most can indeed be availed these therapies. And this brings us to our second potential solution of how we can use a risk-based approach to target costly, resource-intensive, but potentially effective therapies to individuals who need it the most. As part of our risk-based approach, we have developed a machine learning-based risk score called the WATCH-TM score to predict 5-year risk of heart failure among patients with type 2 diabetes. And this work was led by Dr. Matt Seeger, who was a resident at the time and is now a cardiology fellow at Texas Heart Institute in Houston. The WATCH-TM score uses several cardiometabolic risk factors in its risk assessment, which are readily available in the EHR data and have been extensively validated across multiple extension cohorts, including EHR-based registries from UT Southwestern, and most recently in a SGLT2 inhibitor trial, the CANVAS trial. In a secondary analysis of these data from the CANVAS trial, we recently demonstrated that a high WATCH-TM score identified individuals who were more likely to benefit from SGLT2 inhibitors for prevention of heart failure, with much greater reduction, absolute risk reduction for heart failure than individuals who were in the low or intermediate risk groups, as shown in this plot on your right. Similarly, in a secondary analysis from the look-ahead trial data, we also saw a significant interaction between the WATCH-TM risk score and the treatment effect of intensive lifestyle intervention in preventing heart failure among the look-ahead participants, such that individuals with higher WATCH-TM score were more likely to benefit from this intervention than those with lower WATCH-TM score. And these observations do highlight the potential utility of a simple risk score strategy like the WATCH-TM score to target effective heart failure therapies to individuals who need it the most and are most likely to benefit from these therapies. In addition to clinical risk factors that are captured by the WATCH-TM score, cardio biomarkers, particularly high-sensitivity troponin and NT-proBNP, have also been identified as some of the strongest predictors of heart failure risk in the general population and among individuals with diabetes. The data shown on this plot come from a pool cohort analysis that our group did, looking at the strongest predictors of heart failure risk among self-reported Black and white adults who live in the community. And as you can see here, NT-proBNP and high-sensitivity troponin were the top 2 predictors of heart failure risk among Black adults and were among the top 5 predictors among white adults, highlighting the value of these cardiac biomarkers for risk prediction for heart failure in the general population. And we have shown that these biomarkers are particularly useful for risk stratification in the intermediate risk patient population. In another pool cohort study of patients with hypertension and intermediate range blood pressure who were not on antihypertensive therapies, we observed that elevated biomarkers can identify individuals most likely to benefit from intensive blood pressure control with a twofold gradient in the number needed to treat for prevention of adverse cardiovascular events between biomarker negative group that is shown in the blue bar and biomarker positive group that is shown in the red bar in this bar plots. And considering the importance of cardiac biomarker in risk prediction and risk stratification, we incorporated biomarkers in a risk prediction algorithm for heart failure among patients with type 2 diabetes and developed a simple integer-based biomarker risk score that incorporates high sensitivity troponin, NT-proBNP, high sensitivity CRP, and left ventricular hypertrophy presence by EKG to risk stratify patients with type 2 diabetes. And in this study, we demonstrated that the biomarker risk score had really good discrimination and adequate calibration performance and was able to identify individuals most likely to benefit from SGLT2 therapies, such that among those with high biomarker risk score, SGLT2 inhibitor therapies could prevent over 40 heart failure events per 1,000 treated patients over a 5-year period. And in contrast, individuals who had low biomarker score, that number was less than 10. And while both clinical risk score and biomarker-based risk scores can inform heart failure risk prediction, the challenge that we encounter in the real world is how do we use them together in an efficient manner, and who should be screened with biomarkers, and who should be started on therapies just based on their clinical risk profile without requiring potentially resource-intensive biomarker testing. And to address this question, in a recent study, we evaluated the most optimal strategy for combining clinical risk scores and biomarkers such as NT-proBNP for predicting risk of heart failure. We observed that addition of NP levels improved risk prediction performance of a clinical risk score like the WATCH-DM score, and the C index was improved from 0.71 to 0.76. And we also observed that the magnitude of improvement in the discrimination performance with incorporation of biomarkers varied across the distribution of the clinical risk score, and the greatest improvement in performance was noted at the lower end of the score spectrum, which captured the low and intermediate risk patients. So this is similar to how we intend to use or actually use CAC score testing in patients for ASCVD risk, where intermediate risk patients benefit most from potentially expensive CAC scoring. Similarly, intermediate and low risk patients for heart failure risk benefit more from biomarker testing for screening purposes. And we also observed a similar pattern of results for improvement in calibration metrics for incorporation of NT-proBNP in risk assessment across the spectrum of WATCH-DM score, as shown in the plot on your right. So based on these observations, we recently proposed a pragmatic approach to heart failure risk prediction in the health system, at the health system level, in a recent review article in the Lancet Diabetes and Endocrinology Journal. And this approach combines both clinical and biomarker risk prediction tools. Clinical risk scores such as the WATCH-DM can be used initially for risk stratification and to identify individuals who are at a high risk of heart failure. And selective biomarker testing can then be implemented in the subset of participants who are classified as low or intermediate risk patients by the clinical score to up-risk those individuals who may have an underlying substrate that is associated with development of heart failure, but may not have been captured by just their clinical risk profile. And once we have identified the high-risk population using the risk score as well as the biomarker elevation, we can tailor the risk prevention strategies accordingly to target the highest risk individuals. And this, similar to biomarkers, I think there is another strategy that can be leveraged for identifying patients with increased risk of heart failure, and that is echocardiography. And echocardiography can be used for risk stratification among patients with diabetes, similar to cardiac biomarkers. And subclinical abnormalities in cardiac structure and function, as identified by echo among type 2 diabetes patients, can identify the stage B heart failure, which is often referred to as diabetic cardiomyopathy. And in a recent pooled cohort study, we assessed the prevalence of diabetic cardiomyopathy using different definitions of diabetic cardiomyopathy, ranging from a least restrictive definition, which required only one abnormal echo criteria, to a very restrictive definition that required 2 out of 3 abnormal criteria to be present, along with elevated biomarkers. And as you can see on the bar plot on your right, the prevalence of diabetic cardiomyopathy can be as high as 60% using the least restrictive criteria, and up to 10% using the most restrictive criteria. And furthermore, the risk of heart failure is much higher among individuals with diabetic cardiomyopathy by either of the criteria compared to those who did not have diabetic cardiomyopathy prevalent at baseline echocardiographic assessment. And taken together, these observations provide evidence for a risk-based approach to prevention, whereby clinical risk scores such as WATCH-TM can be used for the first level of screening to identify type 2 diabetes patients who are at an increased risk of heart failure and are more likely to benefit from interventions such as SGLT2 inhibitors. And these risk scores can be implemented in the EMR with adequate risk prediction performance and can be combined with more deeper risk assessments using cardiac biomarkers as well as echocardiography in the subset of individuals who were screened to be low intermediate risk at the first level of risk screening to further identify residual risk of heart failure. And this highlights the complementary approach to incorporating both clinical risk scores and cardiac biomarker and imaging efficiently at a health system level to identify patients who are most likely to benefit from expensive pharmacotherapy such as SGLT2 inhibitors or now GLP-1 agonists as well. And future work remains to be done to actually test these strategies out. So coming to the third point regarding the solutions for cardiometabolic and cardiovascular health improvement, while this risk-based approach is potentially useful, the challenge that remains to be tackled is whether it can improve the worsening disparities in cardiometabolic health. And much of the increased risk of adverse outcomes and much of the disparities by race that we observe in our community is driven by high burden of adverse social determinants of health in our community, particularly among participants or individuals of self-reported Black race. And these social determinants of health are largely driven by the neighborhood and the zip codes where patients live and are reflective of systemic and structural racism that impact access to care and better health for these individuals. In a recent study from Medicare cohort, we looked at risk of heart failure among white and Black Medicare beneficiaries living in zip codes with varying proportion of redlined area. And redlining, for those not familiar, refers to this practice by Homeowners Loan Corporation in the 1930s and 40s of systematically denying mortgage and, as a result, home ownership to communities of color. And on the left is one example of redline map where the areas indicated in red were communities deemed hazardous for loans. And although this practice ended by the Fair Housing Act in 1968, to your right, you can see the results of our analysis that show that there's still significant difference in risk of heart failure among individuals who are living in the contemporary era among zip codes with increasing proportions of redlining area. And the data shown here is stratified by Black and white race. And as you can see, for the Black race participants, there is a graded association between increasing proportion of redlined area in the zip codes of residents and risk of heart failure, while that relationship is not observed for the white race Medicare beneficiaries. And much of the excess risk associated with living in redlining area was indeed driven by higher burden of worse social determinants of health and poor neighborhood environment and poor access to care in these areas. And it is important to capture the risk related to this adverse social determinants of health in our risk prediction approaches if we intend to use a risk-based approach to allocation of preventive therapies in efforts to mitigate the existing disparities in cardiovascular health. And to this end, we have developed risk prediction approaches that use novel techniques such as the machine learning approach that can efficiently utilize large multidimensional data, including social determinants of health data, to develop separate models to predict risk of adverse outcomes in self-reported Black and white race adults. As an example of such an approach, we published this paper in Circulation a couple of years back that was led by our fellow Matt Seeger. And in this study, we have used a machine learning-based approach for predicting risk of heart failure among community-based individuals of self-reported Black and white race. Pooling data from multiple community-based cohorts, we developed a random survival forest model to predict the risk of incident heart failure separately across the two race groups and compared its performance to the traditional models of heart failure risk prediction in external validation cohorts. We observed that the ML-based models demonstrated superior performance than other traditional risk prediction models in identifying patients with high risk of developing heart failure. And the question that comes to our mind is, why did the ML models perform so much better than traditional heart failure risk models? The answer is that while the traditional risk models estimated risk using the same set of covariates for individuals of Black and white race, the ML models were more flexible in their data approach and were able to identify unique risk factors for each subgroup, as shown in these plots here. And as you can see, between the Black and white race subgroups, there is a distinct risk profile and distinct profile of risk factors that contribute to the risk of adverse outcomes. And we have subsequently developed similar ML models incorporating social determinants of health to predict risk of even heart failure-related mortality among hospitalized patients, and demonstrated superior performance of models that do incorporate social determinants of health parameters. And furthermore, we observed that the SDOH parameters feature more frequently among the top predictors of adverse outcomes among patients of Black race versus other race groups, highlighting the reasons why their incorporation into the risk prediction model improves their model performance, particularly for patients of self-reported Black race. So most of the solutions we discussed are, while providing us answers to address the gap in utilization of therapies and address the widening disparities, they're only meaningful if we can take them to our patients and bridge the existing implementation gap. In the next few slides, I will highlight some of the initiatives that we have taken in research projects to leverage novel implementation strategies to improve cardiometabolic health, and which can be an example for doing similar implementation science strategies in larger health systems. So one of the examples of an EMR-based approach that we have took to improve implementation and use of SGLT2 inhibitors in patients with diabetes is a pragmatic EMR-based clinical decision support tool trial, in which we are evaluating the utility of implementing the WASH-TM risk score-based treatment approach in our type 2 diabetes patients in our health system. So in this trial, we are testing the clinical decision support tool that leverages the WASH-TM score to inform care providers of the high heart failure risk for their patients with diabetes that they encounter in their outpatient clinic. And once the patient shows up in their clinic, the WASH-TM score is calculated at the back end by the EMR, and the providers will be prompted to consider prescription of SGLT2 inhibitor and consider imaging with echocardiography if the patient is deemed to be high risk based on their WASH-TM score. We are also testing some other innovative approaches to improve care of patients with existing heart failure using similar big data approaches. And one of the examples that I would like to highlight is an ML-based tool to predict diuretic resistance among patients with acute heart failure. And this work was performed as part of an NHLBI data challenge, which our group won. And in this study, we pooled data from 5 heart failure network trials and developed an ML-based approach to identify diuretic resistance. We validated our diuretic resistance phenomapping tool in external cohorts and are implementing it in our UT Southwestern EMR to better identify individuals who may be who may have higher burden of diuretic resistance and thus may need more aggressive diuretic therapy upfront. So here's the example of the ML-based score for diuretic resistance in acute heart failure. It incorporates some of the factors that we know are associated with diuretic resistance, including creatinine, blood pressure, dose of home diuretic, NT-proBNP level, and some comorbidities like hypertension and atrial fibrillation. And we are currently developing this clinical decision support tool that will prompt physicians in the ER for taking a more aggressive diuretic approach among patients who are indeed identified to have higher diuretic resistance. We are also testing this diuretic resistance risk score among patients who have been recently discharged from the hospital to assess whether they may benefit more from alternative diuretic therapy, such as subcutaneous Lasix, which is given by this Furosix drug company, as compared to oral Lasix for the post-discharge period. And these data will tell us whether informed approach to identifying diuretic resistance may indeed may indeed help us in tailoring more aggressive diuretic therapies among these patients. I would also like to highlight a potential role for data science and ML-based approach in understanding treatment of HFpEF, which is a pretty heterogeneous syndrome And we have leveraged the big data and ML approaches to improve our ability to diagnose HFpEF and also identify patients who may benefit from more effective therapies for HFpEF. And specifically, we have developed a deep learning algorithm to identify cardiac phenotype of HFpEF with true diastolic dysfunction. And as you know, up to a third of patients with HFpEF have no cardiac abnormalities at rest, and most cardioprotective therapies have failed in large randomized controlled trials, highlighting a need for better approach to target such therapies in specific patient subgroups. So in this study, our deep learning model of diastolic dysfunction was demonstrated to be superior to the ASC criteria to identify elevated filling pressures, and it was indeed able to identify a higher risk subset of patients with HFpEF who had increased risk of adverse events. And when we tested it in our in the TopCat cohort, which is a trial of spironolactone in HFpEF, we observed that patients who were identified as true diastolic dysfunction by our algorithm had greater benefit from TopCat in the greater benefit from spironolactone in the TopCat trial, with a treatment effect of 0.65 as compared to the low risk non-cardiac phenotype, where the spironolactone treatment was not efficacious in preventing risk of adverse outcomes in the TopCat trial. Again, this highlights the value of using such deep learning model-based phenomapping approaches to actually identify unique subsets of patients with heart failure who may benefit from such therapies. We are also leveraging mHealth-based approaches for management of HFpEF, and to this end, we have implemented a home-based cardiac rehab platform among our HFpEF clinic participants, where we identify older, frail HFpEF patients and have been testing this under a clinical trial setting where patients who are frail and need exercise therapy but are not approved for traditional cardiac rehab are randomized to getting the mHealth-based rehab versus usual care. And we have completed the study and now analyzing the data to see whether this targeted mHealth-based cardiac rehab prescription for these patients may indeed improve their physical function and exercise capacity. So in conclusion, we have learned that big data and ML approaches can guide us in identifying unique subgroups of patients at high risk of developing cardiovascular diseases and who may derive differential benefit from potentially effective but expensive cardiac therapies. Cardiometabolic diseases is influenced both by biological and social factors, and effective management requires recognition of their relative contribution and incorporation of social factors, particularly social determinants of health, in our risk assessment tools. And conventional approaches to chronic disease management fall short, and scalable solutions with rigorous evaluations are needed to address the existing implementation gap in management of cardiovascular risk. I would like to thank my collaborators and funding sources, and happy to take questions here on.
Thank you very much. That was an amazing lecture, and congratulations again on the great work you're doing. So please put if you have any questions in the Q&A, and we'll go through them. I'll start with a question. You mentioned briefly calcium scoring. Any value, have you tested any value of calcium scoring predicting heart failure when it's incorporated into the machine learning algorithms?
So we have, for heart failure risk prediction, we have not really assessed the role of calcium scoring as much. And the challenge with calcium scoring assessment for heart failure is that the data is not as strong on whether calcium scores can predict heart failure risk beyond the ASCVD risk that may precede heart failure development. And I think if you had to put your money for screening, testing for cardiac biomarkers such as NT-proBNP and high-sensitivity troponin have a much more, I guess, impactful role to play in heart failure risk prediction than calcium scoring. Also, I think calcium scoring works really well for statin use, allocation of statin therapies, and I think that's where its role is currently. But it would be interesting to study it to see whether incorporating available calcium risk, calcium score-based risk into these algorithms may improve heart failure risk prediction or not.
Thank you. And I'll ask you one more. There's no question. So what about the sarcopenia? You mentioned sarcopenia. I think is very interesting in this geriatric syndrome. How does that play into the risk model?
Yeah, I think this just highlights the need to assess sarcopenia and physical function more routinely. We have not been able to find data sets or cohorts that have routinely done sarcopenia assessment at baseline and incorporated it in our risk models. But I do think that further phenotyping of patients using anthropometric parameters such as sarcopenia, and also adiposity depots like visceral adiposity and central adiposity is critical to further understanding the contribution of these risk factors to heart disease, particularly heart failure. So we definitely need to work on routine assessments of these anthropometric cardiometabolic parameters and then developing risk models that incorporate these measures in risk assessment.
Thank you. Thank you very much. And you measure adiposity. Is there any difference on the distribution on the adiposity? Have you looked at this?
Yeah, I think we have looked at the association of different adiposity depots with risk of heart failure, and we have seen that visceral adiposity, higher amounts of hepatic fat, higher amounts of skeletal muscle fat infiltration are all associated with increased risk of heart failure. In contrast, I think lower body fat and subcutaneous fat have less of an association with adverse cardiac structure and function and risk of heart failure.
Thank you very much. Yeah, that's why BMI falls short, right, on this. But
yeah, no, definitely. I think BMI has a lot of challenges with its utilization for particularly for heart failure risk assessment. And I think lean body mass is indeed a major component of BMI, where the adverse components are visceral adiposity and skeletal muscle fat, which are often not adequately represented in the crude BMI measure.
Thank you very much. We have a question from Daniel Lorenzati, one of our fellows here that does mostly research and has been leading our efforts. He says, very interesting topic, just a pragmatic question for research. How do you collect the data from the charts? Do you have a deep learning software to extract data from Epic, or what's your approach to build these huge databases you've built?
Yeah, so I think that's a great question. I think for our EMR-based data collection, we have used our Epic analysts and I think Epic queries, where we have provided them the patient population of interest and the clinical variables of interest, and they've been able to extract longitudinal data. And it is really important to collaborate with clinical informaticians and bioinformaticians who can help you with querying the patient population. There's a lot of data that exists in EHR that we don't pay attention to, particularly not the longitudinal data. And I think EHR can be a very rich source of longitudinal data for risk prediction and also understanding the effects of therapies that you introduce during a patient's journey, clinical journey, by looking at changes in risk profile and changes in risk factor profile over time.
Thank you. Yeah, great question, great answer. So thank you very much for the lecture. We'll keep looking forward to reading more papers from you.
Thank you so much.
Hopefully we'll see you at ACC.
Yeah, will do. Thanks. Bye.
Bye-bye.